Hello everyone, today we are starting with the endocrine system and the first topic is thyroid from embryology to pharmacology. But remember that this is not a very detailed video, rather it contains all the high yield points that you need for your MCQs. The first one is embryology. Thyroid gland arises from the floor of the primitive pharynx and then descends downward to the neck. It is connected to the tongue via this duct which is called as thyroglossal duct. The normal remnant is foramen cecum. However, this duct may persist as a cyst in the anterior midline and it will move with swallowing or protrusion of the tongue. The thyroglossal duct may also remain as a pyramidal lobe of the thyroid. Now look at the blood supply of the thyroid. The superior thyroid artery is a branch of the external carotid artery, whereas the inferior thyroid artery is a branch of thyrocervical trunk, which comes from the left subclavian artery. Also remember that inferior thyroid artery, while ligating, is associated with injury to recurrent laryngeal nerve, whereas superior thyroid artery is associated with external laryngeal nerve injury. Now, here comes the thyroid physiology. What happens is thyroid releasing hormone from the hypothalamus comes and acts on the anterior pituitary to release thyroid stimulating hormone. It will act on the thyroid gland to produce T3 and T4 and then they will act on the effector organs. How does thyroid produce T3 and T4? Let's see. This diagram shows three compartments: blood, thyroid follicular cell, and then the follicular lumen. What happens is iodine and sodium enters into the thyroid follicular cell from the blood via this sodium iodine symporter, and then this iodine will be shifted or transported to the follicular lumen. The reaction or the process is called oxidation. Then thyroglobulin from the thyroid follicular cells will come to the follicular lumen and bind this iodine. The process is called as organification. What really happens is inside the thyroglobulin are tyrosine molecules which will bind this iodine. If it binds a single iodine, it is called as MIT, monoiodotyrosine. If it binds two iodine, it is called as diiodotyrosine. And then there comes a coupling when the DIT and MIT are coupled to form T3 or a DIT and DIT are coupled to form T4. Now remember that all these three reactions, oxidation, organification and coupling, are mediated by TPO, thyroid peroxidase. This is the enzyme which is inhibited by propyl thiouracil and methimazole while we are treating hyperthyroidism. What happens next is the thyroglobulin along with the thyroid molecules is endocytosed. The thyroglobulin and tyrosine reduce are recycled to be used in the next absorption and T3 and T4 are released into the blood. Note that in peripheral tissues T4 is converted to T3 by the enzyme 5'-deiodinase and T4 can be converted into RT3 which is metabolically inactive. The conversion of T4 to RT3 is increased by growth hormone and glucocorticoid. Now let's discuss a very important phenomena called as Wolff-Chaikoff effect. This is a protective autoregulatory mechanism. When there is sudden exposure to excess iodine, the thyroid peroxidase is temporarily shut down. The result will be decreased production of T3 and T4. Now, a clinical correlation. Do you know what's a thyroid storm? When the patient is having hyperthyroidism but is incompletely treated or is untreated at all, and then the symptoms of hyperthyroidism will worsen in acute stress. The patient will be in delirium and agitation, etc. So, the treatment protocol we are going to discuss later on, but one of the treatment component is iodide load. What will happen is excess or sudden excess iodide load will turn up thyroid peroxidase and will lead to decreased T4 synthesis due to Wolff-Chaikoff effect. Now, the functions of thyroid hormones. Remember that thyroid hormones are also bound to thyroxine binding globulin in the blood, but only the free hormones are active. And also note that T3 binds nuclear receptor with great affinity than T4. That's why T3 is more potent. Now, the functions of thyroid hormones. The 7 Bs. The first one is brain maturation, the second one is bone growth. And remember that thyroid hormone takes the body to a more active and energetic level. So, on the heart, increase heart rate, increase cardiac output, stroke volume, and contractility. The basal metabolic rate will increase, so there will be increased sodium, potassium, ATPase activity, increased oxygen consumption, body temperature, and respiratory rate. The blood sugar will increase due to increased glycogenolysis and gluconeogenesis, and also there will be increased breakdown of lipids or lipolysis. Important to note is thyroid hormone stimulates surfactant synthesis in babies. Now, the key are high-yield points of hypo and hyperthyroidism. We have already discussed that hyperthyroidism takes the body to a high energy level. So the basal metabolic rate will increase. There will be heat intolerance, increased sweating, and weight loss. The skin will be warm and moist due to vasodilation. So, in contrast, in hypothyroidism, there will be cold intolerance, decreased sweating, weight gain because the basal metabolic rate will decrease, and the skin will be dry and cool due to decreased blood flow. Also remember that hypothyroidism is associated with coarse brittle hair, whereas in hyperthyroidism we have fine hair. In hypothyroidism we have generalized non-pitting edema and puffy faces, where in hyperthyroidism we just have this pre-tibial mixed edema, especially in Graves' disease. Now comparing the ocular changes, in hypothyroidism we have periorbital edema, whereas in hyperthyroidism we can have periorbital edema, but in addition to it we have exophthalmos, that is protrusion of the eyeball, and a lid leg sign. Now important to note is both hypo and hyperthyroidism presents with proximal muscle weakness, but CK will be elevated in hypothyroidism while it will be normal in hyperthyroidism. Also, osteoporosis or fracture risk increases in hyperthyroidism because T3 directly stimulates bone resorption. And most important of all, you have to remember that hypothyroidism leads to carpal tunnel syndrome as well as myoedema, which are small lumps rising on the surface of a muscle when struck with a hammer. In addition, both hypo and hyperthyroidism causes infertility in males and females equally. Now, as we discussed, hypothyroid patient will be hypoactive, whereas hyperthyroidism patient will be hyperactive. The cardiovascular signs and symptoms. Hypothyroidism will present with bradycardia and decreased cardiac output, whereas hyperthyroidism patient will present with tachycardia, palpitations, arrhythmias, chest pain, and systolic hypertension. Now very important to note is the first line investigation in both hypo and hyperthyroidism is TSH. So first you have to measure TSH, and if TSH is low then you have to measure T3 and T4. If they are high, this is hyperthyroidism. If TSH is high and T3 and T4 are low, it is hypothyroidism. Now, as we discussed, hyperthyroidism takes the body to a high energy and an active state. So, more energy will be used, lipids will be broken down, so there will be decreased LDL, HDL, and total cholesterol. In contrast, hypothyroidism will lead to hypercholesterolemia due to decreased LDL receptor expression. Now we are proceeding to those high yield diseases which are very important for your MCQs. The first one is Hashimoto thyroiditis. It is a chronic autoimmune thyroiditis associated with HLA-DR3 and have an increased risk of primary thyroid lymphoma, typically diffuse large B-cell lymphoma. The findings are moderately enlarged non-tender thyroid. On serology, you will get positive anti-thyroid peroxidase or anti-microsomal and anti-thyroglobulin antibodies. And on histology, you will get these Hurthal cells, which are lymphoid aggregates within these germinal centers. And Also note that both Hashimoto thyroiditis and subacute granulomatous thyroiditis can present with a hyperthyroid state, which later on becomes euthyroid and then later on becomes hypothyroid. Let's suppose you are given a patient in a scenario with the symptoms of hyperthyroidism like fine tremors, fine hairs, weight loss, increased cardiac output, stroke volume, heart rate, etc. But on serology, positive anti-thyroid peroxidase antibodies and histology Hurthal cells are clinical finding the thyroid is moderately enlarged. Do not get confused with the signs and symptoms of hyperthyroidism because Hashimoto thyroiditis and subacute granulomatous thyroiditis both can present with this hyperthyroid state and then a euthyroid state or a hypothyroid state. So the patient may have normal thyroid hormone on labs findings and all other findings of Hashimoto thyroiditis or subacute thyroiditis will be given. So do not get confused by these. Now, postpartum thyroiditis is a self-limited variant of Hashimoto thyroiditis and it arises less than 1 year after delivery. So, in scenario, you will be given a pregnant lady who delivers a baby, and then 6 to 8 months after the delivery, the woman will present with the symptoms of either hyperthyroidism, or the patient will be euthyroid, or the patient will be hypothyroid, and you will be given these findings on histology, serology, and clinical findings, and you will have to choose a diagnosis. So in that scenario, you have to choose postpartum thyroiditis or Hashimoto thyroiditis because it's more specific in this scenario. The next is subacute granulomatous thyroiditis, which is also called as D. Corvin thyroiditis. Remember the mnemonic D. Corvin present with pain, so very tender thyroid in addition to the jaw pain, and this is usually preceded by a viral infection. On histology, you will get this granulomatous inflammation, and similar to Hashimoto thyroiditis, it can present with a transient hyperthyroid or a euthyroid state, and later on it becomes hypothyroid. The next is renal thyroiditis, which is also called as invasive fibrous thyroiditis. Invasive because it can extend to local structures like trachea and esophagus, similar to anaplastic carcinoma of the thyroid. And fibrous because thyroid tissue is replaced by this fibrous tissue and inflammatory infiltrate shown in this image. And the clinical findings will be a slowly enlarged, hard, rock-like, fixed, and non-tender thyroid. However, the patient will not present with the symptoms of hypothyroidism, and that occurs only in one-third of the patient. Also note that renal thyroiditis occurs as a part of the IgG4 related spectrum, which include several diseases like autoimmune pancreatitis, retroperitoneal fibrosis, and non-infectious aortitis, etc. The next one is congenital hypothyroidism, which was formerly called as cretinism. It is most commonly caused by either thyroid dysgenesis, so abnormal thyroid gland, or dysharmogenesis, abnormal thyroid hormone production by a thyroid gland. And the findings will be pot belly, puffy-faced child, protruding umbilicus, protuberant tongue, and poor brain development. The next one is a non-thyroidal illness syndrome or euthyroid sick syndrome. You will be given a scenario in which a patient is critically ill or admitted in ICU, and you will get a normal T4 and TSH on the labs but a low T3. So this is typical scenario of non-thyroidal illness syndrome. Now, hyperthyroidism high yield. The first one is Graves' disease, which is the most common cause of hyperthyroidism. What happens is the body produces thyroid stimulating immunoglobulin, which are IgG antibodies, and they will stimulate TSH receptors on thyroid. So, there will be increased production of thyroid hormones, hyperthyroidism, and diffuse goiter. It will act on dermal fibroblasts to cause pretibial myxedema and orbital fibroblasts to cause Graves' orbitopathy. What really happens is thyroid stimulating immunoglobulin will lead to activation of T cells and lymphocytic infiltration of the retroorbital space. The T cells will secrete cytokines like TNF alpha and interferon gamma, and they will act on fibroblasts inside the retroorbital space to secrete hydrophilic gags, and these are osmotically active substances, so they will lead to osmotic muscle swelling and muscle inflammation within the retroorbital space, leading to exophthalmos. Graves' disease often present during stress like pregnancy and is associated with HLA-DR3 and HLA-B8. On histology, you will see tall, crowded follicular epithelial cells with scalloped colloid. Now, toxic multinodular goiter. These are focal patches of the hyperfunctioning follicular cells distended with colloid, and they are working independently of TSH due to TSH receptor mutations. So there will be increased release of T3 and T4 from nodules or focal points on the thyroid gland. Also remember that there are two types of benign nodules on the thyroid: hot nodules and cold nodules. Cold nodules are non-functioning but carry significant risk of transformation into malignancy, while hot nodules are hyperfunctioning nodules and visualized on radioactive iodine scan. They are rarely malignant, but they lead to increased production of T3 and T4 and symptoms of hyperthyroidism. Now, a very high yield topic: thyroid storm. What happens is when a patient is having hyperthyroidism but is incompletely treated or untreated at all, the patient condition significantly worsen in the setting of acute stress like infection, trauma, and surgery, and presents with agitation, delirium, fever, diarrhea, tachyarrhythmias, and coma. There will be deranged LFTs. And what is the treatment? Remember, 4 Ps: propranolol, propylthiouracil, prednisolone, and potassium iodide. Also important to note is we give iodide load in thyroid storm, and that will lead to complete shutdown of thyroid and decreased T3 and T4 synthesis via Wolff-Chaikoff effect, as we discussed earlier. Now the next is thyroid adenoma. We have already discussed that thyroid nodules, benign thyroid nodules, can be of two types: cold and hot. Cold are non-functional, but they carry significant risk of transforming into malignancy. Hot are rarely malignant, but they are hyperfunctioning and can lead to increased thyroid hormone production. The histology is follicular. It means that follicular cells are involved, but there will be absence of capsular invasion and there will be absence of vascular invasion. Remember that an adenoma with the presence of capsular or vascular invasion is follicular carcinoma. And if the scenario says that the capsule and vessels are not invaded, go for thyroid adenoma. Now, very high yield and always necessary to revise before any exam are the thyroid carcinomas, which are typically diagnosed with fine needle aspiration and are treated with thyroidectomy, the only treatment modality. What will be the complications of surgery? Here you can see in this diagram, thyroid gland have on the top of them 4 parathyroid gland which could be removed, and that lead to hypocalcemia. Now note that there could be injury to recurrent laryngeal nerve and could be injury to external laryngeal nerve. So when you are ligating the inferior thyroid artery, you can result in injury to the recurrent laryngeal nerve. And if you are ligating superior thyroid artery, there is a chance of injury to external laryngeal nerve, which is a branch of superior laryngeal nerve. Note down these points. The first one is papillary carcinoma. Let me tell you a scenario. A child present to the OPD with a history of childhood irradiation, and now he has palpable lymph nodes in the neck. And what happens is when you go for the fine needle aspiration cytology and histology, you see empty appearing nuclei with central clearing and samoma bodies. And the parents of the child asks you about the prognosis. What will you say? Remember that papillary thyroid carcinoma is the most prevalent. It can present with palpable lymph node, but it has the best prognosis among eyes. On histology, there will be orphan any eyes and samoma bodies, which could be remembered by this mnemonic: puppy and moma adopted orphan any. Also note that childhood irradiation predisposes to papillary carcinoma. The next one is follicular carcinoma, and we have already discussed that benign thyroid adenoma and follicular carcinoma both involves follicular cells. So fine needle aspiration cytology will not be able to distinguish us because both the cell types are follicular. Remember that follicular carcinoma spread via blood. Hematogenous spread will be given in the scenario, and it invades the tumor capsule and vasculature. If the tumor capsule and vasculature is not invaded, it will be a follicular adenoma, a benign thyroid adenoma. The next one is medullary carcinoma, which arises from the parafollicular C cells which produce calcitonin. On histology, you will get these sheets of polygonal cells in a myeloid stroma, which stains with Congo red stain. The last one is undifferentiated or anaplastic carcinoma, which occurs in older patients. It presents with rapidly enlarging neck mass and have compressive symptoms like dyspnea, dysphagia, and hoarseness, and has very poor prognosis. If you remember, we have already discussed in renal thyroiditis, which is also called as non-invasive fibrous thyroiditis, that it can also have compressive symptoms. So, renal thyroiditis resembles anaplastic carcinoma due to compressive symptoms like dyspnea, dysphagia, and hoarseness. Now, I have left one point intentionally: the mutations associated with each carcinoma. There is no other way than memorizing it. The papillary carcinoma is associated with RET or PTC rearrangements and BRAF mutations, follicular carcinoma with RAS mutation and PAX8 PPAR gamma translocations, medullary carcinoma MIN2A and MIN2B mutations, and anaplastic carcinoma with TP53 mutation. Now, coming to the management. The first category is thionamides, which include two drugs, propyl thiouracil and metamazole. Remember that in the thyroid physiology and the synthesis of thyroid, we have discussed three steps: iodination, organification, and coupling. All the three are mediated by thyroid peroxidase. Now, these two drugs will block thyroid peroxidase and thus blocks the production of thyroid hormones. And PTU, remember, also blocks 5' deiodinase, which was responsible for peripheral conversion of T4 to T3 because T3 is more potent than T4. Now, note the high yield point. PTU, propyl thiouracil, is used in primary or first trimester of pregnancy, and metamazole is used in second and third trimester of pregnancy. PTU is not used in second and third trimester due to PTU-induced hepatotoxicity, and metamazole is not used in first trimester due to its teratogenic effects. It can cause aplasia cutis. Also remember that PTU can cause ANCA-positive vasculitis. One thing that I forgot to tell you while discussing Graves' orbitopathy or ophthalmopathy is you should not treat it with propyl thiouracil or metamazole or anything else. Treat it with glucocorticoids. That's the only treatment modality. Now the last one, levothyroxine T4 and levothyronin T3. Avoid levothyroxine with antacids, bile acid resins, or ferrous sulfate because it decreases its absorption. And the clinical uses are hypothyroidism, obviously, and mixed edema. And the adverse effects are these are thyroid hormones T3 and T4, so the adverse effects are signs and symptoms of hyperthyroidism, tachycardia, heat intolerance, tremors, arrhythmias, etc. Also note that when a patient is taking the drugs levothyroxine and levothyronin, the patient can present with the signs and symptoms of hyperthyroidism. How are you going to distinguish between this exogenous hyperthyroidism from endogenous hyperthyroidism? Go for TSH receptor antibodies, which are positive in endogenous hyperthyroidism. Radioactive iodine uptake will be increased in endogenous hyperthyroidism, and thyroid blood flow on ultrasound will be increased in endogenous hyperthyroidism. This sums it all, thyroid from A to Z. I hope you enjoyed this video. Thanks for watching. Don't forget to follow the First Aid FCPS project.